Hello, I'm pleased to welcome everyone to our program tonight. I want to thank our audience for joining us on a beautiful day around the country, especially here in Boston. I also want to thank our clinical trial sponsors, Amgen, Bristol Myers Squibb, Janssen Oncology, Novartis, Pfizer Oncology, Point Biopharma, Prostate Therapeutics. These organizations make it possible for us to bring this educational program to you. And again, I want to extend our thank you to these organizations. We have a program tonight that I think most people will be interested in. We're going to address and examine unleashing the power of your own immune system. This is an area that will play an increasingly important role in the treatment of cancer. And it's another program that we bring to you as a way of making sure that our members and the public are aware of new developments that will play the next generation, to bring the next generation of therapies to patients. So again, we're excited to bring this program to you tonight, unleashing the power of your own immune system. We certainly want our audience to participate in this program. We know that as we go through new terms, new concepts, that questions do arise. And we invite our audience to participate by asking any questions that you may have during this presentation. And you can submit your question in the Q&A portal on the Zoom webpage, and we will answer those questions once our program is complete. We will not stop the program to answer specific questions, but your question will be kept alive until the end of our program. So please don't hesitate to ask your question. To get our program started, I want to introduce our Dr. Keith Crawford. Dr. Crawford is the Director of Clinical Trials and Patient Education for FIN. Dr. Crawford is excited about this program because he obtained a PhD in immunology, and he always talks to me about immunology. He really believes that immunology can solve all the problems that we have in prostate cancer, and it's the basis that will solve all the issues around cancer. So Keith is excited to be able to make a presentation to you about immunology, and after which he will introduce our guest speaker. And we're excited to have someone with us tonight that will talk about programs that he's involved with one of our key sponsors, Amgen. And so at this point, I am pleased to hand the program off to Dr. Keith Crawford.
All right, thank you, Tom. Well, good afternoon, good evening, everyone. I am very excited about this program because this is an area that I've been talking to Tom about for several years. Let me get my slides up for you. So the first thing I wanted to talk to you about is that we have been hit with COVID, and people have been suffering from COVID over the past 2 or more years. But from COVID, we've learned a lot about the importance of the immune system, about using the importance of vaccinations and therapies that were created, these therapies that help boost the immune system itself, or also help participate in stopping the progression of disease for COVID. Now, that means that the immune system can be augmented. There's this power that exists, and this power can be used to battle prostate cancer. So as you're aware, if you've followed us for a couple of months, you know that we always like to give you some key glossary words that we like to follow, that we would like you to have as we go forward in our conversation. The first thing is it's important to recognize that when we talk about blood, and this is where your immune cells are travel throughout the body. So we have blood, and we know that red blood cells carry oxygen. Okay, so their job is to provide oxygen throughout all of the body. The white blood cells are where we have our protection. So these are cells that contain the cells that provide protection for the body. Not only protection from bacteria and viruses, but also for cancerous growth. We also have platelets and plasma, and think of plasma as a transport medium. Now, a little bit more, and these are high levels, but we want you to know that white blood cells contain some key cells. Now, they're B cells. Now, these B cells produce these antibodies. Now, everyone has heard about antibodies as it relates to your vaccination. And what is your antibody titer? How high is that? Why? It's because antibodies can serve to identify foreign pathogens or identify a cancer that has a specific marker, and plays a role in killing. T cells are also a type of cell that's an immune cell. Now, they can help or they can serve as a killer cell. But in this case, we're talking about them serving as killer cells. And there's a cell that we won't really talk about now, but within future clinical trials and future therapies, you may hear about natural killer cells, NK cells. The next topic I want you to understand is there's a concept called immuno-oncology, which is really cancer immunotherapy. Now, these therapies that work with the body's immune system to prevent, control, and eliminate cancers. Now, that's very important because a lot of people didn't recognize that cancers didn't just automatically just show up. There have been precancerous cells or cancer cells that have been floating in the tissues, but normally the immune system keeps those in check. And something else that we wanted to talk about before, our last presentation or over last month, you heard us talk about these prostate expressed antigens, PSMA. Now you will hear about STEAP1 and DDL3. Now these are highly expressed in prostate cancer, highlighting the potential as a promising target for treatments for prostate cancer. So, how does this immune system work? So I'm looking at the immune system, and I want everyone to look at the immune system and with this image. And like I said before, a picture's worth 1,000 words. Now, the body, your body is a garden. Now your immune system serves, the soil here in the image can serve as your immune system. Now the healthy cells are these good plants, these green ones, but this dandelion looking flower is the weed, is the it's the cancer cell. Now, this is, again, I like images. So you get an idea when we start talking about immuno-oncology and how it works. You have your baseline immune response. Now, just like this Volkswagen, we could soup it up and make it perform better. And that's the same as adding immuno-oncology therapies. So just to get an idea that your baseline immune response can be souped up, jazzed up, or enhanced to help fight cancers. So, screening and monitoring for prostate cancer, it's very important because people who are at high risk, or once you get to that age where you begin testing your PSA, monitoring your PSA levels, and even people who have evidence that there's a low-grade infection or evidence of cancer may not have a procedure, so they may monitor them. So as we said before, this soil is keeping these cancer cells in check. But there may be a point in time where these cancer cells start to increase in numbers. And this is the time when therapies are introduced. So again, with the garden theme, we can have a hand shovel, or we can have radiation, or we can have chemotherapy, or we can have hormone therapy. So surgery, you can have to dig it out. You're going to cut out the cancer, resect the prostate to remove it, or you can use radiation, either an external beam that kind of covers around the area where of interest, or you have the ability to put radioactive seeds inside the prostate, or both. Now with chemotherapy, These are therapies that are looking to modify the machinery inside the cell so the cell doesn't divide as quickly, or more of a hormone therapy where you take away important nutrients that the cancer may need, which these nutrients are really hormones that where they're interfered, and so interfere with the cancer's ability to use those so it can grow. So in each one of these cases, the cancer cell dies or its growth is slowed. But now, what happens if we use these immune therapies that boost the immune system to respond against the disease? Now, this is something new, because what I mentioned before was we've heard this discussion before about COVID and vaccinations and treatments and therapies that have been created to help combat COVID infection. Now, in this case, we use the analogy of weed control fertilizer as the immuno-oncology therapy. So we know that it allows us to selectively kill the prostate cancer cells. So again, in this image here, as I said before, the soil is serving as your immune system. These green plants are your healthy plants. These yellow weeds are the cancer cells. And your immunotherapy is really serving as your weed control fertilizer that selectively, if you move to the right, kills off these cancer cells. And so these are images that we want you to get into your mind, into your head. So when you're speaking with your doctor about treatments such as this or clinical trials that are related to this, you have a point to go back to. You understand how this system works. Now, why is this so important? We recognizing that Finn has a focus on addressing the disparity that exists with African-American men participating in clinical trials. We clearly want more African-American participation in clinical trials. Now, colleagues at Harvard have clearly suggested that at minimum 22% of those people that participate in clinical trials should be African-American or Black Americans. And I wanted to highlight, we talked about immunotherapy, immuno-oncology, but this isn't a new therapy. If we go back to 2003, there was a clinical trial, Provenge, that worked on an immunotherapy, that used an immunotherapy that was extremely promising in a lot of patients. But the problem is that with Black men, there was some interesting evidence that existed in this trial. And it looked as if Black men, African Americans, were performing better with this immunotherapy. They lived longer than other groups. But the problem is there wasn't sufficient enough of Black men participating in the clinical trials. So they couldn't make a definitive statement about this. So it took 7 years from 2010, from FDA approval to 2017, before they can comfortably report that this type of clinical trial, this type of immunotherapy best benefits African-American men. That was 7 years that Black men didn't really have access or didn't know about this type of therapy, or people weren't comfortable at offering this type of therapy to African-American men. To address this, we're just not going to point our finger and say, oh, well, there needs to be more African-American men in clinical trials, and that's a shame. What we did was establish our clinical trial rally. And we created a clinical trial portal called, and you can get to that if you go to fintrials.com. But what we've done is on a monthly basis, we go in and review all the actively recruiting clinical trials in the United States. And then we basically place them into their corresponding bucket. So if a person had a diagnosis of low-risk prostate cancer, which you'll see at the top, we provide them a list of all those clinical trials that are actively recruiting, plus information about our sponsors who may have a clinical trial in that particular bucket. So whether it's low risk or high risk or biochemical recurrence, there are clinical trials that are out there that are actively recruiting. And if they're not actively recruiting, we keep track of those. So once they become active, once they're on clinicaltrials.gov, we'll have that in one of these buckets. So some key takeaways. I want you to understand the immune system. It not only can enhance the protection against disease like SARS-CoV, but can also enhance the treatment for cancers. Another point, immunotherapies. Immunotherapies are therapies that enhance the ability of the immune system to fight off disease. Immuno-Oncology, or another name, cancer immunotherapy, is a form of immunotherapy which boosts your immune system so they can better fight your cancer. Now, we have a special guest. This is Dr. Michael Groaning, and he is the Global Medical Affairs Lead in GU at Amgen. And today, he's going to talk to us about advancing prostate cancer treatment with T-cell engagers and emerging therapeutic targets. Mike, welcome.
Thanks, Keith. I really appreciate that. I always enjoy our meetings and talks like this, and look forward to each time. So thanks for the invite for today. And like Keith said, I was going to talk about the immuno-oncology program that we do have at Amgen, but I wanted to start off with a video. So the slide deck that I have might have some technical terminology in there. So the video, I think, is going to kind of set the stage for everyone to at least have a good visual to go with some of the topics that I'm going to discuss. So let me get that ready for you now. And it's a 5-minute video, so it won't take too long.
Prostate cancer is the second most common cancer and the 5th leading cause of cancer death among men. There are approximately 1.4 million new cases diagnosed globally each year, with a yearly estimated death of 375,000 patients. The disease eventually evolves into metastatic castration-resistant prostate cancer, mCRPC, which is incurable, and has a 5-year survival rate of approximately 30%. Therefore, mCRPC has a high unmet medical need. Prostate-specific membrane antigen, PSMA, is a type 2 integral membrane protein which is upregulated in most prostate tumors, with greater than 85% of advanced prostate cancer cells being PSMA positive. In prostate cancer, PSMA expression levels increase with disease progression and the transition to mCRPC. PSMA overexpression is an indicator of poor prognosis. This makes PSMA an attractive therapeutic target in prostate cancer treatment. When cancer cells develop, effector T cells recognize and bind to tumor antigens, leading to directed lysis of tumor cells. However, some cancer cells develop mechanisms to evade the body's immune system, including the downregulation of MHC class I in prostate cancer. Additionally, prostate cancer cells have low expression of tumor antigens, which reduces the expression of these proteins on the surface of MHCs and T-cell infiltration into the tumor site. This has led to prostate cancer being described as an immunologically cold tumor, rendering the body's natural immune defenses unable to recognize and respond to the tumor. Immunotherapies have had little success in prostate cancer, due in part to this immunologically cold profile. Immunotherapy has the potential to engage between a patient's own T cells and cancer cells, activating the cytotoxic potential of T cells to attack cancer within the cold tumor microenvironment. Amgen continues to advance the potential of immuno-oncology with the versatile and proprietary BiTE, bispecific T-cell engager platform, with the goal of bringing hope to many cancer patients. As an immuno-oncology platform that potentially leads to off-the-shelf therapies, the BiTE platform is designed to recruit the body's own immune system to target and destroy cancer cells. One domain is designed to allow the BiTE molecule to recognize and bind to a tumor-associated antigen. This domain is variable and can be constructed according to the specific tumor being targeted. The other domain is designed to bind to the CD3 epsilon chain within the TCR of T cells. Amgen's BiTE half-life extended, HLE molecules, are innovative proteins that contain a fragment crystallizable, Fc domain that has been designed to enhance the half-life of the BiTE molecules by extending the amount of time spent in circulation. This BiTE molecule is specifically designed to target PSMA on the surface of prostate cancer cells, simultaneously binding to both PSMA and CD3 positive T cells. Once both arms of the BiTE molecule are bound, a cytolytic synapse is formed between the prostate cancer cell and the cytotoxic T cell, activating the T cell and causing it to release perforin, which forms a pore in the prostate cancer cell wall. The cytotoxic T cell releases granzymes through this pore, which induces T cell-mediated lysis of the prostate cancer cells. In addition, BiTE molecule-enabled engagement of T cells induces further T cell proliferation to elicit a more robust response against prostate cancer. As an immuno-oncology platform with the goal of leading to off-the-shelf therapies, the BiTE platform holds potential to help fight cancer using the body's own immune defenses.
So I hope you liked that video. I was surprising Keith and Tom with that video. We've been talking about putting together something like that for some time. And I hope, it kind of provides a good level setting opportunity before we dive into the slide deck.
And I'm waiting to use it.
Yeah, no, I thought you might like that, So let me get this started. Hold on. All right. So I'll go through these slides relatively quick, and then that way you could hopefully benefit from hearing the exchange between Keith and myself talking about this. So again, like they mentioned in the introduction, I'm our global medical affairs lead for the genitourinary programs that we have. And we'll talk about advancing prostate cancer treatments using these BiTE products that we were just seeing in that video. So again, we'll have like a couple slides just for some level setting. I know this audience probably doesn't really need that, but we'll go through that pretty quickly. And that's just discussing the unmet need in prostate cancer, especially with a focus on mCRPC. That's where our programs currently are being explored. And then we'll go into the review of the role of immunotherapies, including these BiTE products that we were talking about. And then lastly, I'll go over the 3 different targets that we're working on as emerging therapeutic targets. One of which is already kind of a validated target. That's PSMA, the one that you just saw in that video. So prostate cancer is, one of the most significant causes of cancer-related deaths in men worldwide. It's just on that video and just reiterating here, as you go down this table here, you can see the high level of incidence. So that's the number of cases that show up each year and the mortality rates that are there as well. So it's relatively high. It's, #1 cause of cancer deaths in men. And most of the men who do get diagnosed with prostate cancer at some point will progress to advanced disease. So up to 20% of the men advance to that CRPC setting of the disease. So that's when they receive androgen deprivation therapy and they no longer respond to that. So they progress into that next stage of disease. So the men who do have this castration-resistant prostate cancer, over 84% of them will have metastases present for the most part. And the prognosis of that, when you get to that stage, is actually relatively low. The predicted survival rate in mCRPC is around 2 years. And that varies a little bit if you're in that first line setting or more advanced setting. So that 24 months is kind of the average between those two settings along that patient journey. And the next part, and again, this probably isn't that new of a concept to this audience, but one of the big things about prostate cancer is its skeletal complications. So the metastases that typically occur in prostate cancer are directed into the skeleton. So that causes a lot of bone pain, pathological fractures, cord compressions, all of these things that really do impact quality of life, which does decrease as the disease advances. Least of which comes from the bone pain, impairment of your physical functioning, either because of those pathological fractures, or the cord compressions in the spine. And obviously all that results in sleep disturbances that just, again, really decreases the quality of life for those that have this. So this unmet need that we see in this, late stage prostate cancer is kind of due to the fact that over the last 20 years, the standard of care has primarily been hormonal therapy, whether it's the androgen deprivation or the AR signaling inhibitor products that you see like Zytiga or Xtandi, which are probably familiar for a lot of folks, and then taxanes. And despite the improved outcomes with these novel hormone therapies, only about 30 to, let's round it up to 80% of patients respond to these therapies without further progression. So there is a wide range of responses with those therapies. So that, just points to the need for coming up with new therapies that we could use, least of which would be different mechanisms of action for those. So the standard care treatments, they slow the progression, but they don't really, shrink the tumors or, reduce the disease-related symptoms. And although novel hormone therapies have improved outcomes in a lot of patients, again, metastatic castration-resistant prostate cancer is still incurable and difficult to treat. So as Keith alluded to, one of the things that we are focused on is in the immunotherapy space and trying to utilize, the immune system that everybody has. So we'll just go through this slide starting at the top left and work our way around. So one of the things that we're excited about, at least with our platform, is the fact that, there are multiple tumor-associated antigens. And what we mean by that, it's almost like, if you think about, if you live in an apartment complex, again, trying to draw some analogies like Keith was making with the gardens and the cars, which I really like. So let's say, the cancer is, that big apartment complex, and you have multiple units inside. So you have all these different addresses. So you can think of these tumor-associated antigens as different addresses within that complex. So if you're trying to get into the complex, you can go after these different addresses. So the tumor-associated antigens would be things like PSMA or STEAP1 or DLL3. So that's something you can do as opposed to something that's a broader, less specific type of therapy, like these broader hormonal therapies or taxanes. So then what we want to do is stimulate the patient's own immune response system. And with that, the thought is, a lot of times you'll hear in the literature or at, different presentations, the tail of the curve. And what they mean by that is when you look at kind of a response curve or a survival curve, you want to see something where that thing doesn't get too close down to the baseline or zero. You want to have it where you do see a drop, obviously, but it'll kind of plateau where a lot of folks will just have a very long, durable response. And that's what we're looking for with these immunotherapies. And then the other part is modulating the tumor microenvironment. How can we enhance the engagement of the immune system? And we'll get to that here in a little bit, but as you saw in the video, one of the reasons why this has been a challenge in prostate cancer is that there is this, this process where it's considered a cold tumor. It's something where the immune system doesn't really respond to the presence of those, those lesions or those metastases. And then lastly, on the bottom left, disruption of the inhibitory signaling pathways, and again, this is kind of what I'm talking about, where you almost have this immune escape mechanism. And like Keith mentioned with COVID, some of the terminology we heard about, especially when the vaccines came out, was this, immune escape mechanism, where these different variants now kind of evolve in a way that they no longer are recognized by the immune system that's been boosted with that vaccination. So that's something that we try to restore with the therapies that we have. So what are the barriers that are remaining with immunotherapies? So despite, these advances and with Provenge that Keith talked about, we have other, immune therapies or immunotherapies. You might have heard like Keytruda or Opdivo, different terms like that. These are things that, have not been as successful as one might think. There's been limited effect in a very limited population. And again, looking off to the right here, just that reiteration that prostate cancer has often been regarded as a cold tumor, which means that these T cells that need to infiltrate the tumor, they just can't do that. So that's what needs to occur in order for the immune response to, to have an effect. So what are some of the factors, at least biologically, that contribute to this? And the tumor microenvironment, that's really just talking about, what's going on with that tumor and the environment around that, as opposed to, other traditional systems that you might be familiar with. Like if you have a virus and your immune system goes and attacks that, again, similar to the COVID example that Keith gave. So there are an abundance of immunosuppressive components, that exist. Regulatory T cells, fibroblasts, things like that make this a challenge with prostate cancer. In the middle, there's a low tumor mutation burden. And that's one of the things, you might hear talked about when people are talking about therapies like Keytruda, where at least with the clinical guidelines that exist, they're looking for something that's oftentimes has the acronym of TMB, or a tumor mutational burden. And you want to have something that does have a lot of tumor mutational burden for those types of therapies to work. And that's not the case with all prostate cancers. And then lastly, this loss of this MHC class 1 expression. So really what that is trying to say is, you might have heard in the video where they talked about the TCR. So this is the T cell receptor. So the T cell receptor, what we're talking about there is that T cell receptor has to recognize something on the tumor cell, which is this major histocompatibility complex. So that's what the MHC stands for. So that's kind of the homing device on the tumor to let the immune system recognize it. And the fact that that expression is low just means that we don't hit a level where it's high enough to cause your immune system to actually react to its presence. So immunotherapy options, they still remain a bit limited. And here are some of the reasons why that's the case. So the last slide just talked about what are some of the biological reasons why there's been limitations. And here are some of the other reasons why it hasn't really taken hold just yet. And part of it is, the adoption of these therapies in clinical practice is pretty complicated. And the reason behind that is that if you've heard of people talk about CAR T therapy, or even with the Provenge that Keith talked about, a lot of times people refer to that as autologous therapies. And what that autologous part means is that they have to, withdraw blood, or they take blood from the patient, and then they have to, extract out the T cells in there, and they manipulate them and then reintroduce that to the patient. So this administration process is a bit cumbersome. It makes it problematic because with these therapies, at least with the CAR T therapies, there has to be specific licenses and training that occur with those for these sites to be eligible to use it. So that just makes it burdensome and has affected some of the uptake in these large demand areas like prostate cancer. And then a significant portion of the patients aren't really eligible for that therapy based on the guidelines. Like I mentioned, the clinical guidelines for prostate cancer as it relates to Keytruda says that the patient needs to have a microsatellite instability of a high degree. So an MSI high, you'll see in the guidelines. And there's just a small percentage of patients that actually meet that criteria. So they don't even qualify for that therapy, at least according to the clinical guidelines. And then lastly, the limited clinical benefit that's seen. And since it is a small subset, it just doesn't have the impact that one would hope to have for broad adoption. So those are some of the barriers that exist for that therapy. So what are we trying to do to address these barriers and make a difference? And as you can see here in this kind of a pinwheel chart, the investigational T-cell engager platform, what we have are multiple options that I'll go over in the next couple slides to talk about that. So the BiTE molecule you see on the top, again, just to reiterate what that is, it's a bispecific T-cell engager. So the purple portion you see targets the T-cell, and the other side targets the cancer cell. And it just draws those two together to get that effect. And then this HLE, what that stands for is a half-life extended BiTE molecule. So you saw in the video how they talked about this crystallizable fragment that's attached to it. And that just helps the, you know, some of the characteristics of that therapy to make it a little more amenable for convenience for the patient, really. So it doesn't have to be administered as frequently, for example. And then moving down, this part that says XmAb, so this bispecific antibody there, it's something that Amgen does in collaboration with a company called Xencor. And it's just another type of platform that's used to, you know, activate the immune system in this bispecific manner, this T-cell engager. And then lastly, Amgen had an acquisition of a company in the fall last year called TeneoBio, and they have something referred to as a UniAb bispecific T-cell engager. And what's different about that, you might remember from the video where it talked about, you know, binding with the epsilon region of the what's called a CD3 receptor on the T-cell. And what that does is when it mentioned the mechanism of action, how it releases these perforins and granzymes, another thing that can occur, and again, since Keith mentioned, you know, a lot of things we learned during COVID, one of the side effects of these drugs is something called cytokine release syndrome. And it's a side effect that kind of has to occur because these cytokines are released, and that's part of what causes the, you know, the response we want. We want that cytokine release to occur to cause the cell death to, you know, to happen with the cancer cells. But what that also does, it causes what's called a cytokine release syndrome. It's like an immune response. And sometimes you heard about that during COVID, that's what's really happening with some of the patients that had issues where they had an overactive or a hyper response immunologically, and that's what caused some of the issues. So we don't have anything like that. That thing I'm describing with COVID is considered a cytokine storm type of situation, and a cytokine release is something different. So, you know, don't confuse those two, but just something to talk about why this UniAb bispecific is so interesting, because it actually has a slightly lesser affinity to the T cell, so that it still causes that synapse to form that was described in the video, but it doesn't necessarily propagate that cytokine release at the same extent that could cause some of these cytokine release syndrome effects. So that's what's exciting about that one. It just modulates some of that response to make it a little bit more amenable for patients or easier on patients. So the antigens that I want to talk about are the three that are in our portfolio at the moment. And like that video mentioned, what's interesting about these bispecifics is that it's kind of you know, modular in the way that it's constructed, where you can change one side of the molecule to be attracted to different things on the tumor cell surface, while the other side can be targeted to the T cell. So why that's important is that, let's say, you have a certain type of prostate cancer that doesn't express the prostate-specific membrane antigen as much as other patients. So what would you do in that case? We still want to have options for those patients. So that's why we're exploring this other target called STEAP1 for short, but that stands for 6-transmembrane epithelial antigen of prostate. So that's another one that's specific to prostate cancer, that perhaps patients have that expression more so than the PSMA expression. And then lastly, the one that we're pretty excited about is the DLL3 target, and that's the delta-like ligand. And that's something that is still being explored, and its presence in very advanced stage prostate cancer that's oftentimes considered neuroendocrine prostate cancer, so the NEPC. So those are the 3 targets that we have clinical trials running on at the moment, and I'll go through each one here pretty quickly so we can get to the discussion between Keith and myself. So PSMA, of those 3 targets, is the one that currently is clinically validated. And why we can say that now is that there was a recent approval you probably heard about PSMA radioligand therapy. So that was something I actually helped work on when I was at Novartis before moving to Amgen. And with the VISION study, that was looking at PSMA targeted radioligand therapy. And that was a positive trial and then resulted in an FDA approval of Pluvicto. So that's something that validates PSMA as a clinical target. So that's something that we're working on, looking at that and how we could use that as a target to help with the immune recognition that we're talking about with our platform. Next was STEAP1. And again, this one is also overexpressed. The first slide that I showed you showing all 3 of those targets didn't really give the details, but here, what we've seen in different models and different studies is that it's overexpressed in over 80% of prostate cancers, including bone and lymph node metastases. So that's just something that, is great to see, because that gives us another option if someone either doesn't respond to PSMA targeted therapy, or they want to try this first before they go to something, that they know that works. And then lastly, DLL3, like I said, it's another target of interest that we're looking at. It's expressed in a lot of the neuroendocrine prostate cancer samples that we've looked at. So you can see the number there, 77%. Of those samples expressed prostate cancer, or of DLL3, and then 64% of those cancer cells had that target. So that's something that we see in the very advanced late stage population that we're really excited about. So this is the second to last slide. And again, this is just to kind of capture the commitment that Amgen has on developing these targeted immunotherapies. Like I mentioned, we do have these targets in our pipeline. We have 2 PSMA targeted products that are in clinical trials right now, 1 STEAP1 target bispecific that's in clinical trials, and a DLL3 product. So there's 4 programs that are moving forward at Amgen looking at all of these. So just to wrap things up as a summary, so we know that prostate cancer is a significant cause of cancer-related death. That's not anything new to this audience, but it's something we're very committed to. And despite recent advances in solid tumors, immunotherapies are still one of those things that have limited benefit. So we want to find a way to work around that. And we feel like we have with these T-cell engagers that represent a class of novel immunotherapies that help engage a patient's own immune system. And we have these 3 targets that we just kind of went through pretty quickly that are highly expressed in prostate cancer. So we're hoping that, exploring those will help, develop promising treatments for patients who have prostate cancer. So with that, I will stop sharing and we could start some of the Q&A and discussion with Keith.
Well, Mike, thank you very much. That's a lot of information, and we're going to kind of dive in and ask questions. First question that came up was, so a person has metastatic castration-resistant prostate cancer and they want to participate in a clinical trial, how do you decide on which one of these trials a patient would use or try to go for?
Yeah, that's a good question. So that's a conversation, obviously, that would be best had with your physician. And, there are a few things that you could do to kind of decide what that might be. And if you've had participation or you've had prior therapies that target PSMA, you might want to look at, a STEAP1 targeted therapy. Again, just because if you progressed on one target or of interest, you might want to look at another target of interest. And then as far as the DLL3 bispecific that we have, again, that would be somebody who has very advanced disease. There's a lot of, I should say not a lot of, there's a lack of consensus, I think, in, the community as far as how does one define somebody as a neuroendocrine prostate cancer patient? It's got a lot of terminology you see in the literature. Some will call it treatment emergent prostate cancer or treatment emergent neuroendocrine prostate cancer. Some will call it just an aggressive variant of mCRPC. So, we're looking at ways on trying to define what that patient population is. But for the DLL3 program, that's really for people who have neuroendocrine or small cell like prostate cancer. So when you're trying to decide which one of these trials you might be interested in, it has to do with both your prior therapies and where you are in that journey. I would say the DLL3 trial is really for very advanced late stage prostate cancer.
Okay. All right. And then, thank you. Then there was another question. Excuse me.
Oh, bless you.
There was another question about, could you better explain or elaborate more on this cytokine release syndrome versus cytokine storm?
So if you can think of it this way, so cytokine release syndrome would be, let's say you've got a electric stove, right? And you turn on your, you turn on the stove and you have it on like a low simmer. And that's something that you want to, let's say we're just heating up some milk for a grandchild or something like that, right? And that would be something where you have cytokine release. You've got like this heat emanating, but it's in a controlled fashion. So cytokine release syndrome, you've got these cytokines that are released, but it's in a controlled way in a sense, or a finite level. But cytokine storm, let's say you've got that same electric stove, but the wiring is faulty or mixed up, or it's pretty old. So you turn it on low, but something in that system doesn't have it just sit at that low temperature. It just turns it red hot and you can't do anything about it. So you almost think of, cytokine storm as like a runaway, system where it doesn't stop. It just keeps releasing these cytokines and it causes this effect that, can't be shut down. So that's what a cytokine storm is. Cytokine release syndrome is where you have the cytokines that are released, but it's at a slightly elevated amount, that could cause, various things, that might occur. So, for those of you, here's a good example to talk about some cytokine release. So I have my Fitbit that I wear all the time. It talks about or gives me information on my sleep, how well I slept. It'll even give body temperature and it'll give heart rate and things like that. And I know when I got my vaccine, especially after the second shot, I got the Moderna vaccine, my heart rate was probably 20 beats higher, the day after I got it. The body or skin temperature was higher. But then the next night, it was fine. It was back down to the normal amounts. So when your body responds and you have these, your immune system activated, in that case, you have this response where it causes things like fever, or it causes things like tachycardia or elevated heart rate. And it comes to a certain level, but then it'll go back down. So that's cytokine release syndrome like. Cytokine storm would be it just runs away. It just keeps increasing and, gets progressively worse. So it's a very long-winded example, but wanted to give a couple just to relate the difference.
I think it was helpful because a lot of people think that this isn't new to this clinical trial. I mean,
Mm-hmm.
the release of cytokines and elevated temperature, elevated body heat happens all the time.
Mm-hmm.
I mean, we can go back when your first organ transplant, isn't that there's a cytokine release?
Right. We have an immune response there.
There's still an autoimmune response that accompanies a treatment. And so just wanted to make sure that and it was perfect. Thank you for answering the question, because I think the person would better understand the difference between the two. It's something that's there. Now, another question is you mentioned something about autologous.
Mm-hmm.
And so, okay, so now you have to have this autologous treatment versus allo treatment. So the Amgens, 340, 509, and 757 clinical trials, these are not autologous, but they're allo treatment, like the therapies coming off the shelf.
Exactly. Yeah. And that's how, that's the biggest, I should say biggest, that's one of the big differentiations between, CAR T therapy and things like Provenge, where you have to harvest something from the patient's body, manipulate it, and then reintroduce it. So what the bispecific platform, allows is that you don't have to do anything with the patient's, blood, or taking any type of, sample or something that you have to extract. You can just introduce the therapy just like you have any other infusion. If you've been on something like a docetaxel, or if you have your ADT and you have like a Lupron injection, you're just injecting it into the patient and it does its business. You don't have to harvest something from the patient, manipulate it, and reintroduce it. So it's a way of engaging T cells. It's a way of hoping to activate the immune system without having to harvest something from the patient first before you do that.
Well, if that's the case, then it's almost like an off-the-shelf immunotherapy.
Exactly. Yeah.
Well, I mean, and I think for the future, I mean, that's something that could be a game changer when we start talking about having to go to an academic center where there's a lot of sophisticated technology and there has to be a lot of specialists, where conceivably you could move to the community care setting, to the community health centers or groups like that may be able to provide treatment, as long as they have time to monitor the patient.
Exactly. And that's one of the things we're excited about, the concept of off the shelf, because it does broaden access, and especially, to this audience, that's one of the big things that we're interested in, right? We want to be able to broaden the access where it could be available at a community cancer center. You don't have to go to a big academic center or tertiary care center. So, those are things we're trying to explore with these products. Mm-hmm.
And so it addresses some of those barriers that you spoke about earlier.
Right.
And so there was one question about mechanism of action. That's I know what that means, but I think this will probably be the last question.
No, you're fine.
Yeah, but if you can elaborate on, is it antibody based, or is it the cell that's killing the cancer? What's going on? How is that? What's the mechanism of action?
Yeah, so as far as the mechanism of action, and we'll just try to compare and contrast just to let people know, when you think of a mechanism of action, it's how something works. So it's basically, how do these things work in the body to cause the effect that you're hoping to get? Prostate cancer is a very androgen-driven, disease. And that's why they have a lot of hormonal therapies, right? Because you want to block that mechanism or that cascade of events on androgen and how it feeds the disease. Taxanes, they work in a different way, where they kind of interrupt cell division and things like that, with different tubulin things. And those are like the little strings that kind of help pull the cells apart. So the mechanism of action for what we're doing, it basically is, binding one component, is going to the T cell, and then the other component is going to the cancer cell. So it just brings them together. It's almost like, again, if you've got, grandkids or kids, if you they're trying to teach a young one to play catch, right? And you have that kind of disc that they would, wear on their hand like a glove, and it's got Velcro on it, and you just toss the tennis ball, and the tennis ball would stick to it, right? So that's essentially what we're trying to do here, where you could think of that Velcro disc that you kind of put on your kid's hand, and that could be, let's say, the T cell, and then the tennis ball, the fuzzy tennis ball, is the cancer cell. When they come together, they stick. And then, think of the bispecific as that, coming together of these two things. If you just had like a smooth plate, the ball's just going to hit it and fall off. And that's typically what would happen with, your immune system and prostate cancer, because it doesn't have a recognition mechanism that's naturally there. So if you put the little, the hooks of the Velcro on that disc, throw a tennis ball, now it'll stick. And then it can do like we saw in that video, where the porphyrins are released and the granzymes are put there, but they have to get stuck to each other first for that to happen. So the mechanism of action, the way to think about it with these bispecifics, is that Velcro toy that you have with your kids or grandkids, and you throw the tennis ball at it and it can stick to it, so that the immune system can do what it naturally does.
Right.
Yep, I have a couple more questions, Keith. So, Dr. Groaning, one question is, even if you eliminate the 85% of cells expressing PSMA, won't the remaining 15% of cells propagate, and then PSMA targeted therapy would no longer work for that patient?
Yeah, so that's a great question. So one of the things that we, are looking at, and the data is still being generated, to show this, is that you can come up with, when you bring the T cell or the immune system in to this cluster of prostate cancer cells, not all of them may express PSMA, but if the one that's adjoining it expresses PSMA and that T cell is right there, it could develop, you have memory T cells, and they can come back and they'll recognize these things on the cell surface even without the bispecific present. So what we're hoping is that once you get the T cells that can infiltrate that tumor, so sometimes you'll see a term called tumor infiltrating lymphocytes. So what you do is you kind of bring those T cells or those lymphocytes into the tumor, and now they'll kind of consume, or they'll, cause the cell death of all those that are around. Obviously you may not get 100%, and hopefully, you can get enough where you can prolong that patient's life long enough to where, they could enjoy, the time they have there, or, it'll be so slow growing that, they'll die of other natural causes, before that happens. And that has to do with when I mentioned this tail of the curve concept, where you can have such a long, durable response. The immune system is still activated enough to continue cleaning things up, like Keith mentioned in the very beginning. So that's one of the things, that we're hoping, even if you don't have 100% expression, that enough expression can occur that you could have this propagation of T cells that can, go on to carry out their business.
Excellent.
Oh, Tom, I had one other. The question is, but what about the addition of STEEP? Do you have any information about the relationship between, in that 15% that Tom mentioned that may not be PSMA positive? You have another clinical trial, another therapy, in the pipeline that may be able to address that gap, which is STEEP.
And that's something that we're looking at pretty actively, actually. And how does one sequence these things, right? And it could be something like you're describing. We could also look at would be things like, what if you combine a PSMA targeted therapy with a STEAP1 therapy? And it doesn't have to be both immune therapies. What if it's a PSMA radioligand therapy with the STEAP1 immunotherapy? So all those questions are being asked, and hopefully we can generate data to explore that. But those are good questions, and that's why, like I said, we have this robust portfolio where we hope that if someone can't respond to PSMA, they could respond potentially to STEAP1, and then if they progress, further down that, that treatment or that patient journey, when they get to the point where they have the neuroendocrine like prostate cancer, now we've got DLL3 that you could bring in. So, that's the idea, that we have multiple, shots on goal to help the patient along these different stages of their journey, to help.
There's another question. In view of these exciting therapies that are now under clinical trial, when is your first treatment potentially going to be available?
So that's a good question too. And obviously these things have to go through the normal process of the clinical trials. But we're looking, at least with the PSMA and the STEAP1 targeted therapies, it may not be commercially available till 2026, 2027 time period. But in the meantime, there are clinical trials that are actively going on. Like Keith mentioned, those are on the FIN website. And we're in phase 1 with all 3 of these programs at the moment. But once we get to a phase 3, that's when it becomes, I wouldn't say available in a commercial sense, but those clinical trials are normally much larger, and they're not doing any type of dose exploration or any other type of more, detailed investigations that need to happen at that time. It's usually, let's just get this out to as many patients as we need, for that registration, so they can be several hundred patients that could have access to these during those phase 3 trials.
Sure. And I would like to leave this message with our audience, and that is immunotherapy is an area that we've spent a lot of time at FIN focusing on, not just because it's Dr. Crawford's area of specialty, but when you go back to Provenge, and Dr. Crawford presented the Provenge history, the registry that they collected and presented the results in 2017 showed that the Provenge immunotherapy had a better survival outcome for Black men than other men. And so we're very anxious to make certain that we bring these immunotherapy clinical trials to the attention of Black patients now, because as you said, Dr. Groaning, there is, while we may not have the treatments available until 2024, 26, clinical trials are treatments. And so we want to I want to strongly encourage our audience to go to our website, look at these clinical trial opportunities, and they may be available to you now, not all of them, but some of them. And so please consider these clinical trials as part of your treatment option.
And then I wanted to add something along with that, Tom, is that I mentioned before, we have a clinical trial rally, where our clinical trial rally is expanding, and we've incorporated something, learning sessions, where we're taking the patients and put them in contact with the clinical trial sites. So keep monitoring our site, because we'll be having more and more information about this, how you can participate in these learning sessions in your community. So I just wanted to mention that, so everybody knows that there's continually more education, more information about these novel therapies that are coming down the pipeline.
Absolutely. And another thing that I'd like to point out to our audience, we covered a lot of complex terms today for you. And I know I didn't grasp everything in detail, and I doubt that many of you did. But this presentation will be available on our website under fintv.com.
Right.
So you will have the opportunity to go back, study this material, the information, and be able to have a better appreciation of what is taking place in this important area of immuno-oncology. Again, we're very excited about it. We think it could have a great impact on prostate cancer for all men, and especially Black men. We have the highest death rate of any man, more than 2 times greater. And so when you look at areas of metastatic castration-resistant, neuroendocrine, those are phases that patients will go through. So what Dr. Groaning presented are therapies that are under study for those areas. So again, I encourage you to go to fintv.com, understand this material. Dr. Crawford took it from a garden viewpoint, to make it simple. And Dr. Groaning took us to another level. But I think if you look at them long enough, you'll be able to tie them together. But again, I emphasize, consider participating in one of these clinical trials.
And they can always, don't forget, you can always call.
You can always give us a call. If you have questions, please call us.
Yeah.
Excellent. So, Dr. Crawford, I know one of the things that we always do, we like to do, is to give our audience a chance to provide us some feedback on how well we did with this program. So you see before you now where you can, I'd love to get your feedback on this program. Mm-hmm. So take a few minutes and fill this out. And then I think you will will see the results. We try to bring new ideas, new concepts, new therapies to you through these programs. And it's important that we be on target with what we're doing. So please take time and give us your feedback. And while you were doing that, I would just like to say to Dr. Groaning, that was an outstanding presentation. We greatly appreciate it. I love that video, and we're going to use that video to help demonstrate and explain some of your clinical trials. So so thank you very much for that.
No, I'm happy to do it. Like I said, I always love meeting up with you guys, and I knew you'd like that video, especially after some of the feedback, Keith.
Yeah. A picture's worth 1,000 words.
That's right.
So just while we're waiting, we're going to focus on 3 or 4 different clinical trials. And what were those clinical trials for our audience again that they could take a look at?
So one is for a product called AMG 340, and that's the PSMA targeted therapy. And then the other one is for our STEAP1 product is called AMG 509, and that's active and enrolling. And then for those that have the neuroendocrine prostate cancer, that's AMG 757 is its code.
Okay.
And all 3 of those are open and enrolling. But like I said, they're all in phase 1 right now. And hopefully sometime, by the end of 2023, we plan to go into phase 3 with, with AMG 509 and 340, hopefully.
So both of these, the 340, both of them metastatic castration resistant patients?
Yes, they're all for metastatic castration resistant. The 757 trial, that's the only one, like I said, is for neuroendocrine prostate cancer, but it's pretty widely, broadly defined. Again, like I said, there's not a lot of consensus on, how one defines those patients. So we didn't want to make it too restrictive.
How does a patient go about it? Because I guess the majority of patients may know, if they do know, that they have an adeno form of prostate cancer, but this neuroendocrine, do they ask their doctor? Would their doctor know if there's anything special that they have to?
Yeah, no, that's a great question. So, and that's one of the exciting things about DLL3 and its development as a target. At the moment, I'm only aware of one clinical site, which is MSK, so Memorial Sloan Kettering, where they have an imaging agent that is looking at DLL3 expression. So normally the way a patient might know they have a neuroendocrine phenotype or a neuroendocrine type of prostate cancer is through clinical means. They've either progressed very quickly through, the therapies that they've had. What can happen sometimes too is you'll see the disease burden increase, but the PSA values will actually decrease or plateau. So when you start to transition into neuroendocrine prostate cancer, and I know a lot of folks with prostate cancer are very, acutely aware of their PSA values. So what one might see when they have very advanced disease, their PSA values increase, but then when they start to transition to neuroendocrine prostate cancer, those PSA values actually will go down, but their tumor burden goes up.
Oh, okay.
So that's one way you can kind of tell. So at the moment, it's oftentimes kind of determine clinically or through inference of what therapies that you've failed. So normally what you'll see patients get in that space would be if you end up going on platinum therapy, or etoposide is another common one that's used in that space. So you can tell by the types of therapies people are on. So they fail, all traditional standards of care.
Okay. And then there was one question about these forms of therapy, especially if it's in metastatic castration-resistant disease. Does it have a protective effect or decrease bone fractures, or what treatments are available to help decrease bone fractures?
So none of the therapies that I talked about actually do that inherently, but luckily Amgen does have another product that's commercially available called Xgeva, or you might know it as denosumab.
Yeah.
So there are bone health agents that are available, and even if you don't have a lot of bone disease, that's a good idea to have a bone health agent. And again, this is just repeating some of the data that's out there. This is not a recommendation. You should talk to your physician about that type of thing. But, the data does show that when you have your androgen deprivation therapy, your bone density also goes down. So one of the side effects of the therapy that you take, even most basic, androgen deprivation, can cause a decrease in bone density, and you get fragility of the bones through a lot of the therapies that you have to have. And then on top of that, when you start to have a lot of bone disease, that also can cause some type of symptomatic skeletal, fractures or different things like that. So, some data suggests that 50%, or the fracture rate is around 50% for prostate cancer patients, over the course of their disease. Half of the patients will have some type of fracture or bone event like that. So having a bone health agent, I think, is important no matter where you are in your, in your journey.
So it should improve the quality of life.
Yes.
Especially if you're prolonging life and you want healthy bones.
Right, because oftentimes what we mentioned even on that one of the slides we had was the quality of life is decreased when you start to have those spinal cord compressions, which could come from a fracture or break in the your vertebrae or in your spine. That could cause some of these issues to occur, and then just the pain in the bone and everything that's associated with that. So it can help with the quality of life having some type of bone health agent.
Again, I want to thank our audience for staying with us. And I want to thank you for the feedback that you provided. And I want to thank Dr. Groaning again for his presentation, and also Dr. Crawford. So we hit the mark according to our audience, and that's all we're going to ask for. Now, we're asking our audience to look at these clinical trials and consider your participation. With that, I don't have anything else. Dr. Crawford, do you have anything?
No.
Dr. Groaning, do you have anything? Any lasting comments?
No, I mean, thank you again for the invite. Like I said, love talking with you guys, and hope people can walk away with at least one or two things that they liked or learned, and hopefully it'll help them out.
Fantastic. Thank you so much. And again, I want to thank our audience. I want to thank our sponsors for making this presentation possible. With that, we're going to say good night, and we'll see you at our next program.